Welcome, everyone. Thank you for joining us this afternoon for our QI Grand Rounds, Uncertainty in the NICU, the case of bronchopulmonary dysplasia. Just a note that our session today will run from 3 till 4:15. We are so thrilled to have our wonderful presenters with us. They include Dr. Roger Saul, Dr. Eric Jensen, and Dr. John Zupancic. We also have some discussants and guest faculty with us, including Dr. Jeffrey Horbar, Dr. Danielle Errett, Dr. Erica Edwards, and my name is Denise Zayak. I'm your host. As a brief caution, this clinical presentation may trigger sensitive reflections for parents. If there are any parents with you today viewing, please take the time to support them and debrief with them after the presentation to understand their journey and to provide them with support. Thank you. Our agenda today, we are going to open with a wonderful encore recording from Chicago 2019, opening with Dr. Roger Saul, Uncertainty in the NICU, Eric Jensen, What is BPD? And John Zupancic, Network Meta-Analysis of Steroids for BPD. We're then going to transition to our live section, and both Eric and John will present us with a few slides and updates on their work since their previous presentation. Dr. Saul will moderate the discussion and Q&A, and then we'll move to next steps. So I'm happy to now introduce our first speaker, Dr. Roger Saul, and sit back and enjoy this presentation. Thank you.
I'm Roger Saul. I'm president of Vermont Oxford Network and director of clinical trials and follow-up. I'm also coordinating editor of Cochrane Neonatal. And I'd like to share with you my issues around uncertainty, with a specific focus on bronchopulmonary dysplasia. My disclosure are the roles that I mentioned at Vermont Oxford and Cochrane, and because of those roles, I have constantly been thinking about this issue of uncertainty. In particular, as you know, I'm very fond of talking about what evidence we have, but I have gotten more involved in the process of recommendations. I've been invited to help ILCOR with their recommendations regarding newborn resuscitation. And this translation of what we think the evidence is and what we know we should do is so rife with uncertainty that I thought as a general theme this is well worth discussing. And when I think of the one issue that probably lends itself best to this, it was bronchopulmonary dysplasia. So many of our efforts have been focused on interventions that we assume should decrease the risk of bronchopulmonary dysplasia. If we look at data in the Vaughan network on very low birth weight infants, we see incredible practice changes that are evidence-based and really should lead to decreasing respiratory morbidities. Antenatal corticosteroids have increased over the past 2 decades, such that greater than 8 out of every 10 very low birth weight infants are now exposed. When we look at our delivery room practices, we have adopted much less invasive approaches. Many fewer infants are intubated in the delivery room in the past 20 years, and we continue to stand ready for those who are intubated to use evidence-based practices regarding surfactant treatment and administer surfactant as early as possible. Over 8 out of 10 infants now at some point in time in their NICU course is supported non-invasively with nasal CPAP. And in fact, if we look at the earlier part of this century, we see this change in practice that is probably as dramatic as any changes of practice we could think of. This is looking at data on babies 501 to 1,500 grams from 2000 to 2009, and I doubt you've ever looked at a figure that shows so much change. Many more infants being given antenatal steroids, many more infants being supported with CPAP, as I noted. And yet, when we look at these changes, as Jeff spoke earlier, we see few changes when it comes to chronic lung disease. We know that this matters. We know it matters to parents. It adds days to hospitalization. It adds to rehospitalization. And importantly, looking here at Barb Schmidt's work, it is a risk factor for developmental problems almost equal to brain injury. So what I'd like to talk about this morning are some very basic issues around our management. And I'd like to start with perhaps the most straightforward, how we define bronchopulmonary dysplasia. What do we mean when we say BPD? You'd think that understanding what a disease is would be a rather simple process. It seems that we should have an intuitive grasp on this. And yet we know that it's actually surprisingly hard. Diseases, as they're described, change over time, which is from a variety of factors. Some of it is expectations of what health is. So for example, many diseases in geriatrics, which used to be thought, oh, well, that just happens with age, that's a given, are now thought of as diseases worthy of treatment and research. Diagnostic ability changes, as do social and economic issues. How does this reflect our understanding of BPD? Well, I think you're all aware that this was first described in the late 60s by Northway and colleagues. And they were looking at a very different population of infants. They were looking at infants over 30 weeks gestation who were managed with what was then relatively crude volume ventilators. This was an injury then seen in our more mature preterm infants, and therefore defined during the first month of life, based on oxygen need and radiographic findings. It wasn't until Shannon and colleagues took a look at the fact that this definition was no longer serving us well, that as we treated smaller and smaller and less mature babies, being in oxygen at 28 days had little meaning. And I've heard people say that we just plucked 36 weeks out of the air as a cut point, but actually Shannon's work, I think, gives us a strong justification. So if we look at this figure that is adopted from Shannon's work, we see, if we look at the initial gestational age on your left, and then the corrected gestational age along the x-axis, we see that at 28 days, the green stars, that doesn't predict poor pulmonary outcome at all. It isn't until we look in that window between 34 and 36 weeks gestation does being in oxygen have any clinically relevant meaning in terms of follow-up. And so in fact, at least in the hands of the physicians in Toronto, being in oxygen between 34 to 36 weeks gestation meant that over half of the infants would have concerning pulmonary outcomes. And yet now we think of BPD in such more complex ways. As smaller babies live, we think of this as a developmental disorder of the lung. We think that there are a variety of phenotypes. But then I ask you, how many diseases are just defined because you're in a certain place at a point of time, as opposed to the underlying phenotypes and pathologies described here, the pulmonary vascular disease associated with BPD, the airway disease, the parenchymal disease. These really are more at the core, and we hardly touch them with our current definitions. This is a proposal from the workshop in 2018, and frankly, it makes my head spin. I'm not going to waste Eric's time. You've got to clear this up for us. But there are so many categories. The introduced death as part of the definition. I'm uncertain that this definition is going to help us move forward with greater understanding. So why do we need a better definition? Towards what end? And actually, there are many reasons to consider a more refined definition, to understand the population that we need to prevent BPD. As we look for treatments and even innovative treatments, when we think of mesenchymal stem cells, we really need to know the patients that could benefit. And for our purposes in quality improvement as a metric. But there is something that worries me very much in this whole process. I have heard people say, literally, that the reason we haven't shown the efficacy of certain drugs is because we have the wrong measurement of BPD, and I don't think that's the case. And so we'll hear a little bit about how we measure, how we define, and what purposes we can put that to. Then what about the therapies themselves? We have quite a variety of therapies, some of which are well proven, others of which are just our habits and customs. But there's clearly no therapy more potent than giving postnatal steroid therapy to these infants. But there's also few therapies that we introduce that concern us more than the use of postnatal steroids. Here, looking at the Cochrane reviews and just plucking out the best and the worst of what we do with steroids, it clearly has an incredible reduction, whether we use them early, which we've shied away from, obviously, because of concerns with outcome, or late, we see tremendous reductions in BPD defined at 36 weeks postmenstrual age. But we certainly, when it comes to early studies, see a very concerning risk of almost doubling the risk of cerebral palsy. And although we've all grown a little comfortable with late postnatal steroids, that confidence interval there for cerebral palsy is consistent with meaningful harms and even possible benefits, but it's really uncertain. The recommendations, as you know, are strong, but our practice, although altered by those recommendations, still persists. Around 8% of infants do get at least a single treatment of a postnatal corticosteroids sometime in their NICU course. We're probably influenced intuitively by what Doyle described in the meta-regression, which says that at some point in time, the risk of chronic lung disease itself, of being on a ventilator, of having hypoxic episodes, et cetera, is concerning enough that it carries a developmental risk unrelated to the treatment with steroids. But yet that's unproven. We still need to know which patient to treat, which product, and which route. And yet we don't have a lot of new evidence on which to base these decisions. There are several more recent trials of hydrocortisone, and we'll hear a little bit about them this morning. But in fact, we have to look at the existing data and try to squeeze more from it. And so John Zupancic this morning will talk to us about the evidence base as we know it, but also where we can possibly take the current evidence. I'm very used to getting in front of you guys and talking about direct comparisons. Steroids versus placebo, steroid versus another steroid head-to-head. And that's the sort of comparison that we're all used to dealing with in making our decisions. But there are more sophisticated approaches, and we'll hear about those from John this morning. So, I knew who to call on when I'm feeling lost and confused to help with these two issues. First, we're going to hear from Eric Jensen regarding the definition of BPD, and John Zupancic to talk to us about the status of the evidence on steroids and whether or not these more innovative analyses can help us understand things further. The first will be Eric Jensen. He's the assistant professor of pediatrics at the Children's Hospital of Philadelphia, a person who I think is truly a rising star in our field and someone who I think has given more thought to this issue of how we should think about BPD, how we should define BPD, and what the criteria for those definitions should be. And so, Eric, come join us.
Thank you, Roger, for the invitation to speak here, and thank you for that incredibly uplifting story. Answering the question, what is BPD, is a challenge. The more we learn about this disease, the more we recognize fundamental gaps in our knowledge of its pathophysiology and the outcomes that it endures. To the best of my knowledge, BPD is a chronic heterogeneous disease related to the lungs and the heart and the vasculature that results from arrest of lung development secondary to preterm birth and the combination of injury and abnormal host response from both perinatal and postnatal exposures. This figure from a paper by Alan Jobe nicely summarizes our current understanding of the sequence of events that leads to the development of BPD. The left side of the slides begins with the intrauterine origins of the disease. After birth, premature infants are exposed to numerous pro-inflammatory stimuli, and depending on the burden of these insults and the infant's response, a child either develops chronic respiratory insufficiency that we define as BPD, or the infant does not. However, operationalizing this very complex figure into a definition of a disease is not a simple task. And so as a result, all commonly used diagnostic criteria for BPD rely, at least in part, on the use of supplemental oxygen and/or ventilatory support as proxy measures for the chronic lung injury that stems from these physiologic processes. The 2001 NIH consensus definition of BPD is a prime example of this. These criteria state that among infants born less than 32 weeks gestation, who were treated with supplemental oxygen for at least 28 days, BPD severity is defined at 36 weeks postmenstrual age based on the amount of supplemental oxygen and the mode of respiratory support utilized at that time point. This definition has served as an essential tool to foster clinical care, parental counseling, and BPD research for nearly 2 decades. However, limitations to this definition have emerged over time. Firstly, these criteria do not account for the now common use of high-flow nasal cannula at 36 weeks postmenstrual age. Secondly, the requirement that infants must be treated with supplemental oxygen for at least 28 days prior to 36 weeks postmenstrual age is often either omitted completely in studies that attempt to apply this definition, or it is misinterpreted as a singular assessment of oxygen use on day 28. Thirdly, the need for supplemental oxygen is infrequently determined objectively. Although the oxygen reduction test was designed to overcome this limitation, less than 10% of recent studies reporting BPD as an outcome performed an oxygen reduction challenge. And finally, the 2001 definition may not optimally stratify disease severity or predict long-term outcomes. To illustrate this final point, I propose these 3 infants as case examples. Each infant was born at 28 weeks gestation and is shown here at 36 weeks postmenstrual age. While each meets the diagnostic criteria for severe BPD, current data suggests that the long-term outcomes for these infants are likely to be different. We know that the baby on your right is now at much higher risk of long-term morbidity than the infant on your left. Owing to these limitations, there have been increasing calls for the development of a new definition of BPD. To work towards this goal, a group of us in the NICHD Neonatal Research Network questioned whether we could use a data-driven approach rather than expert consensus to develop a contemporary definition of BPD that overcomes several weaknesses in the current diagnostic criteria and improves our ability to predict which infants will and will not experience poor respiratory health in childhood. This morning, I'm very happy to share our work on this project. Our first step was to identify 3 key questions we sought to answer. Our first question was how best to classify disease severity among infants treated with high versus low flow nasal cannula at 36 weeks postmenstrual age. Secondly, we asked whether infants treated with invasive respiratory support at 36 weeks postmenstrual age should be classified into a unique severity stratum. And lastly, we wanted to know whether the current requirement that infants receive 28 days of supplemental oxygen prior to 36 weeks postmenstrual age helps or hinders our ability to predict respiratory impairment. To answer these 3 questions, we constructed 18 different severity-graded definitions of BPD. The first of these definitions are shown here. Each row in the figure represents a different definition. Disease severity is graded numerically according to the mode of respiratory support and the amount of supplemental oxygen prescribed at 36 weeks postmenstrual age or discharged to home if it occurred earlier. These 3 definitions were designed to address our first knowledge gap: how best to classify nasal cannula use at 36 weeks postmenstrual age. Definition number 1 was constructed to closely mimic the 2001 NIH consensus definition, with the modification that the currently unclassifiable infants receiving high-flow nasal cannula are grouped with those receiving positive airway pressure. Definitions 2 and 3 then modify this initial framework, varying how BPD severity is graded depending on the cannula flow rate and the level of supplemental oxygen. Definitions 4 through 9 were designed to evaluate our second knowledge gap: whether including a new higher severity grade for infants receiving invasive mechanical respiratory support at 36 weeks postmenstrual age improves predictive accuracy. These 6 definitions are the same as definitions 1 through 3, but include a new severity grade for invasive respiratory support, first with and then without stratification by oxygen level. And finally, definitions 10 through 18 address our third knowledge gap: whether the current requirement that infants must receive supplemental oxygen for at least 28 days prior to 36 weeks helps or hinders predictive accuracy. These final definitions are the same as 1 through 9, but only assess the presence and severity of BPD at 36 weeks postmenstrual age, regardless of whether an infant receives supplemental oxygen prior to that time point. Using these 18 definitions, we determined which one best predicted whether or not an infant would develop a primary study outcome of death after 36 weeks postmenstrual age or serious respiratory morbidity assessed at 18 to 26-month follow-up. And we asked that same question for a secondary outcome of late death or moderate to severe neurodevelopmental impairment. Our study cohort consisted of a recent selection of 2,677 varied preterm infants enrolled in the Neonatal Research Network. The primary component of our respiratory morbidity is defined here. It is tracheostomy placed anytime between birth and follow-up, continued hospitalization at or beyond 50 weeks postmenstrual age for a respiratory reason, use of supplemental oxygen, respiratory support, or respiratory monitoring at 18 to 26-month follow-up, or 2 or more rehospitalizations for respiratory reasons prior to follow-up. Shown here are the results of our primary study outcome. Of all 18 definitions, the BPD definition with the highest accuracy for predicting both adverse respiratory and adverse neurologic outcomes through 2 years of life classified BPD severity according to the mode of respiratory support administered at 36 weeks postmenstrual age, irrespective of the current level or prior duration of oxygen therapy. Using this definition, infants breathing in room air at 36 weeks postmenstrual age do not have BPD. Those treated with low-flow nasal cannula have grade 1 BPD. Those treated with high-flow nasal cannula or non-invasive positive airway pressure have grade 2 BPD, and those treated with invasive respiratory support have grade 3 BPD. This definition correctly predicted the presence or absence of late death or serious respiratory morbidity in 81% of the study infants. Of note, the definition designed to closely mimic the 2001 NIH consensus definition was among the least accurate predictors of both of our study outcomes. So while we were in the middle of carrying out this analysis, the NICHD sponsored a workshop that proposed the definition shown here. This definition included some features that we are unable to evaluate in our analysis, such as the presence of abnormal radiographic findings. However, in comparing the main components of the definition, the various levels of respiratory support administered at 36 weeks postmenstrual age, we found that the optimal definition identified in our data-driven approach produced significantly greater accuracy for predicting adverse 2-year outcomes. This is indicated by the higher C statistics shown at the bottom of the slide. One of our goals throughout this project was to develop a BPD definition that would be useful for disease benchmarking. And we recognized that some organizations may need to alter their current data collection instruments in order to be able to apply the definition that we've developed. The Vermont Oxford Network provides a salient example of this. VON currently defines high-flow nasal cannula as a flow rate greater than or equal to 1 liter per minute. Our definition defines it as a flow greater than 2. So we wanted to investigate which approach produced better prognostic accuracy. To do so, we kept all components of the optimal definition the same, except for the flow rate used to define high-flow nasal cannula. Comparing these two options, we found that defining high-flow nasal cannula using 2 liters per minute, as we did in the original definition, enabled more better outcome prediction. So switching gears now, I'd like to spend a few minutes talking about the epidemiology of the disease as we apply the definition that we've developed. Shown here, we used infants who had an average gestational age of 26 to 27 weeks, and among those, 29% were breathing in room air at 36 weeks postmenstrual age and did not have BPD. Grade 1 BPD was the most common, found in 39%, and grade 3 BPD was the least common, found in 9%. Rates of the primary and secondary composite 2-year outcomes rose in a stepwise manner as BPD severity increased. Late death or serious respiratory morbidity, shown on the left, increased from 10% among infants without BPD to 77% among infants with grade 3 BPD. 1/3 of infants without BPD died or developed moderate to severe neurologic impairment, underscoring the impact of prematurity on this outcome. However, the outcome rate rose to almost 80% among infants with grade 3 BPD. Fortunately, rates of late death were relatively low among infants with grade 2 BPD or less. However, they increased quite dramatically to 20% among infants with grade 3 BPD. This means that 1 in every 5 study infants treated with invasive mechanical ventilation at 36 weeks postmenstrual age died in their first 2 years. Shown here are the 6 individual respiratory outcomes. Each demonstrated a stepwise increase in outcome rate as BPD severity increased. Most striking is the 3- to 5-fold increase in all but 1 among infants with grade 3 versus grade 2 BPD. 1/4 of infants with grade 3 BPD underwent tracheostomy. Nearly 50% remained in the hospital for respiratory reasons 2.5 months after their due date. Nearly 1/3 were still receiving supplemental oxygen at 2-year follow-up. So I hope that the data-driven process that I've shown you here today, as well as the stark differences in outcome rates, will convince you that this new pragmatic definition of BPD overcomes many of the limitations of our current diagnostic criteria and provides a better means to predict meaningful childhood outcomes. However, I respect that any wrangling with the definition of BPD is likely to create controversy. And we certainly don't have time for me to go through all of the potential issues that may arise, but I would like to spend just the next few minutes touching on a few. Firstly, in recent years, there has been growing discussion and debate as to whether BPD should be diagnosed at some other time point other than 36 weeks postmenstrual age, and often 40 weeks is proposed as a more suitable alternative. Unfortunately, our data set does not allow us to determine how our definition would perform at alternative time points. However, studies have asked this question for a dichotomous or a yes-no definition of BPD. And my reading of that literature suggests that the best time to diagnose BPD remains uncertain. As Roger told us just a few moments ago, in the 1980s, Andrew Shannon and his colleagues identified that the 36-week time point was a better predictor of 2-year outcomes than oxygen use at 28 days. Over a decade later, Peter Davis and colleagues, using data from the TIP trial, showed that supplemental oxygen use at 36 weeks postmenstrual age was the better predictor of adverse pulmonary outcomes at 18 months, but that oxygen use at 40 weeks better predicted poor neurologic outcomes. And most recently, Isayama et al., using data from the Canadian Neonatal Network, found roughly the opposite as the TIP investigators. Despite these differences, I think what is more important from these studies is that they share a common trend in their data. That is the presence of a clear trade-off between specificity and sensitivity. These 3 graphs show results from the 3 studies described on the previous slide. And in each case, the sensitivity, shown in red, increases, while the specificity, shown in blue, the sensitivity shown in red decreases, while the specificity shown in blue increases as the time when BPD is diagnosed moves later and later along the x-axis. So to remind myself how to interpret these 2 test statistics, I rely on the monikers spin and snout. A high specificity indicates that a positive test, in this case the presence of BPD, likely rules in the disease in question, here a poor 2-year outcome. In contrast, a high sensitivity indicates that a negative test, the absence of BPD, likely rules out the disease, meaning that a baby without BPD is likely to survive without morbidity. In practical terms, the gain in specificity means that if we move the diagnosis of BPD to 40 weeks rather than 36 weeks, we will be more confident that infants who are diagnosed with BPD at that later age will go on to experience childhood respiratory morbidity. However, the loss of sensitivity means that we will be less confident that infants who are classified as not having BPD will survive without adverse respiratory health. Clearly, there is a trade-off here. But if you lament the fact that some infants who are classified as not having BPD at 36 weeks postmenstrual age go on to experience childhood respiratory morbidity, moving the diagnosis of BPD to 40 weeks will make that problem worse. A valid and long-standing criticism is that we define BPD based on its treatment and not objective measures of its pathophysiology, genetics, or even its response to its therapies. There are many ongoing research efforts that I hope will eventually allow us to change this paradigm. One example is a recent study from CHOP, where we sought to define BPD phenotypes among infants with severe lung disease. Employing lung CT, echocardiogram, and bronchoscopy, we were able to subclassify infants based on the presence or absence of moderate to severe parenchymal lung abnormalities, pulmonary arterial hypertension, and large airway malacia. Correlating these disease components within hospital outcomes, we observed a stepwise increase in morbidity rate as the number or count of these disease components rose. Others have taken a different approach. The group from Nationwide Children's found that infant PFTs allowed them to classify infants into obstructive, restrictive, or mixed respiratory physiology. An excellent feature of this study is that they were able to tie these different subgroups to a treatment response, in this case, whether or not an infant benefited from bronchodilator therapy. Studies such as these are getting us closer to a new paradigm in how we define BPD. However, I would argue that we are not yet at the point where we can abandon a treatment-based definition. Across the two studies I just showed you were 4 different diagnostic tests. Other investigators are exploring additional diagnostic tools, such as MRI, biomarkers, and measures of ventilation perfusion mismatch. At some point, we will need to whittle the pool of tests down to a reasonable subset. To do so, we must identify diagnostic tools with adequate reproducibility and, if relevant, inter-rater reliability. We will need to decide if we expect to perform these tests in all infants or only in a subset. The answer to this question will likely help dictate whether these tests must be available in all neonatal care settings or only in high-level units caring for our sickest infants. Finally, we must determine whether we will use these tests to diagnose one disease that we will continue to call BPD, or in fact, BPD will end up being a number of different disease entities that are all diagnosed separately. Lastly, a new definition will, and in and of itself, not prevent the disease. Among infants in the Vermont Oxford network with known respiratory support data at 36 weeks postmenstrual age, rates of BPD have not improved in recent years. It is my hope, however, that with better stratification of disease severity using a pragmatic, evidence-based definition, we will be able to support research and quality initiatives that help us move the needle and improve outcomes. So to conclude, our study working group is proposing a new severity-graded definition of BPD that defines the disease according to the mode of respiratory support administered at 36 weeks postmenstrual age, irrespective of the level or prior duration of oxygen therapy. This new definition overcomes several limitations of existing diagnostic criteria. It will improve our ability to discriminate between infants who will and will not experience adverse respiratory health in childhood, and I hope foster the development of new therapies to prevent the disease and to help in the development of a future physiology-based definition. Thank you to my study co-investigators, the NRN, and to you for your kind attention.
I wanted to call on someone who I think is as committed to evidence-based medicine as I am, but a whole lot smarter, to figure out some of the new techniques that we can use to look at the current evidence. And so we invited John Zupancic, the Associate Professor of Pediatrics at the Harvard Medical School and the Associate Chief of Neonatology at Beth Israel Deaconess.
So how does this fit into uncertainty? The issue is that I think many of us go to the scientific literature more like a Rorschach test to support whatever our pre-existing biases are. And the more that we understand that literature, the more that we'll be able to wring out of it, and the more that we'll be able to reduce the uncertainty, hopefully, in how we apply therapies to our babies and families. So we broadened the idea of this from network and meta-analysis a little bit to how we synthesize the evidence around BPD treatment and prevention across multiple types of analysis. This was a collaborative effort of the Cochrane folks, Colleen Ovelman and Roger, and Susanna Hay, who's a colleague of ours at Beth Israel Deaconess, did the analyses and really led this effort. She's doing some wonderful work. So there are three key questions I'm going to try to answer today. The first is, how do we know what we know in medicine? How do we reduce uncertainty? The second is, what do we know about therapies for BPD? And thirdly, and importantly, what don't we know? Now, as I said, the way that we look at the literature tends to be a little bit of a black box. And so it's really important for us to understand not only how to read an article about a randomized trial and understand what the limitations of that trial are in terms of how it was done and how it can be applied to our patients, but also how we combine the results from multiple investigators into a treatment decision. So I'm going to try to open up this black box a little bit for us today. First of all, of course, we read randomized trials as a way of trying to establish unbiased estimates of how our therapies are working. But there are problems with looking at single randomized trials, as you know. Many of them are too small. They are too small to show what we hope they'll show, or they result in confidence limits around them that are too broad. They may be too specific to one center. They don't include any context because they're done in a particular setting. We just heard about the differences in practice in Canadian units versus some others. They may be badly done. This is obviously a major issue with some of our trials. Or they may just be unlucky, that you do one trial, it doesn't happen to show something, and that's just a statistical glitch. And for that reason, it's become common in medicine to try to combine randomized trials, and we do that in something called meta-analysis, which you hear the results of quite a lot, but we don't actually necessarily go over what that is for folks who aren't really in the weeds of it all the time. So this is what traditional meta-analysis looks like. You take one randomized trial, and you take whatever the outcome was from it, and then you take the second randomized trial and you look at what the outcome was from that, and you do that for all of the trials that have been produced, and you try to assess the quality, and then if they can be lumped in together, then you come up with one estimate of what the literature shows. And that seems pretty easy on one slide. It's actually about a year's worth of work. So we should thank Roger for everything that he's done in generating those and making them available to us. Here's what the traditional meta-analysis have shown around the use of steroids in BPD prevention and treatment. Early dexamethasone, which is defined as, for these purposes, as dexamethasone that's administered less than or equal to 7 days of gestation, has a number of short-term and medium-term positive effects. It reduces the rate of BPD at 28 days and at 36 weeks using traditional definitions. It reduces the rates of death in BPD at 28 and 36 weeks. It makes it more likely that you will extubate by day 7. It reduces ROP and PDA, and then it reduces the need for later use of corticosteroids. On the other hand, as we all know, it has a number of short-term and important long-term effects. So hypertension and hyperglycemia are significantly increased, the rate of GI perforation and hemorrhage, and of course, we know that cerebral palsy is substantially and significantly increased. In fact, if instead of using these rates, we apply something called the number needed to treat, we get something that's intuitive, I think, to people who aren't used to doing this. It basically shows that for every, say, 14 patients who are treated, one will avoid death or BPD at 36 weeks, but one will develop cerebral palsy. That's a powerful effect. And it was because of that result that essentially we stopped using early dexamethasone in the late 1990s, as you heard about. How about late dexamethasone? Well, Roger showed a meta-regression by Lex Doyle that essentially showed that this maybe didn't have the same risks as early dexamethasone. So here we see, if we look at the numbers needed to treat, that we would have to treat 6 babies with late dexamethasone after 7 days of life to reduce one case of, or avoid one case of death or BPD. And that there was, although there was an increase in abnormal neurological examination in a small number of these studies, sub-study, or a subsection of the studies that were done, there was no difference in the point estimate in the average of cerebral palsy or death or cerebral palsy, although, as Roger said, there's some confidence bound around that. There's some residual uncertainty. Overall, though, it does seem that those long-term risks that we talked about for early dexamethasone are at least less than they are for late dexamethasone. than they are for early dexamethasone. So how about hydrocortisone, early hydrocortisone? Well, the traditional meta-analysis for hydrocortisone also shows a decrease in death or BPD at 36 weeks, but it comes at the cost of an increase in gastrointestinal perforation. So for every 2 babies treated, 1 will have a GI perforation according to that meta-analysis, and 2 will avoid death or BPD. So there's a potential for improvement, but it comes at a particular cost. And in small studies, it did not show any difference in cerebral palsy or death or cerebral palsy. So meta-analysis can give us some really important information. And before I go further, I should say that there's no information on other steroids that's been available through randomized trials and entered into these analyses. The problem with this way of combining studies is that first of all, you can't see below the author's publication choices. So meta-analysis is basically just looking at the paper that was published, sometimes contacting the authors, but essentially it's looking at decisions that were made around individual randomized trials. And so that you can imagine might be limited by publication bias, for example. You can't control for other confounders that the authors decided not to control for. So what if gestational age you think was an important predictor, or some of the issues that Eric was talking about were important for how they measured outcomes? That can't be done using traditional meta-analysis usually, and you can't standardize the outcomes and exposures across trials. One trial might use one definition of BPD and another trial might use the other, and trying to combine those is difficult. So for that reason, the next type of aggregation we can talk about is something called an individual patient data meta-analysis. And this looks like this. So here's what we just went over as a traditional meta-analysis, where we take the results from individual trials and put them into one pot. In an individual patient meta-analysis, rather than taking the trial report, we get a hold of all the data from the individual patients, and we put those all into a pot, and we analyze them as if it was one big randomized trial that we have access to. There are a few of these done in neonatology, and the one that's most important for us today is the one that was done by Schaefer and Christy Waterberg and colleagues. It analyzed the results of patients from 4 trials. Importantly, there are actually 5 trials of early treatment of hydrocortisone in very preterm infants. They were only able to get the data for 4, but it's still 1,000 patients, and that would be a reasonable trial if we did that, if we had done that as a single multi-center study. And basically what this individual patient meta-analysis shows is that early hydrocortisone, less than or equal to 7 days, does in fact reduce death or BPD at 36 weeks, but as we said, one trial was missing from that. It does that at the cost of GI perforation, but now what we can tell, because we have access to the individual patient data, we can tell that GI perforation only happens when the baby's also got indomethacin. So it reduces our uncertainty around that. And then finally, late onset sepsis was increased significantly in babies who got early hydrocortisone. But again, that was mostly in babies who had pre-existing chorioamnionitis, interestingly. So by having access to the individual patients, we actually have lots more information that can reduce our level of uncertainty. But it doesn't make it all go away. This is what we know at the point of having the traditional meta-analyses and the individual patient data meta-analysis. We know that early hydrocortisone improves survival without BPD and probably doesn't increase cerebral palsy. We know that it does increase GI perforation and late onset sepsis, but as I said, there were reasons and patient populations in which that happened and could probably be avoided. That it improves short-term outcomes, including survival if given early without BPD, that early dexamethasone improves those outcomes, but it increases cerebral palsy with a reasonable amount of certainty. And that if we give late dexamethasone, it does improve survival without BPD and doesn't seem to increase CP or NDI. So what don't we know? Well, one of the things we don't know is whether the prednisolone that is given pretty frequently in my unit is actually effective or safe. We don't know what happens if you give early hydrocortisone and then have to give dexamethasone later on in your course. Is that worse than waiting and giving late dexamethasone? Which patients should get which drug? Where should we draw a line on patients? Should we use inhaled versus systemic therapy? What about low dose versus high dose dexamethasone? Or what about a direct comparison of hydrocortisone versus dexamethasone? Well, the first three of these can be answered just by undertaking new trials, and probably they're questions that have to be answered with new trials. We can't make up data when there's none there, and the observational studies are kind of a mess. The last three, though, have some signals, some information that is still present in the trials that have been done, and that it's possible we can access by some techniques that basically wring that information out of those trials. And that's what I'm going to talk about now, something called network meta-analysis. You're going to be hearing a lot about network meta-analysis in the coming years. You can see on this graph the increase in the number of citations, the increase in number of network meta-analyses in PubMed over time. There are now over 3,300 network meta-analyses, although there are only a small handful in neonatology. So how do these things work? Well, they start out basically drawing a graph of the evidence. And on this graph, we have dots, which we call nodes. Each of those dots represents or is a separate treatment. So here we have a dot for placebo, and we have a dot for treatment A, which might be dexamethasone. And then we connect those dots using a line that's called an edge, and that line represents one trial, or more than one trial, that has compared those two particular interventions. And we can go through and draw all of the different kinds of comparisons that have been done. So in this evidence landscape, we see that two treatments have been tested. Both of them have been tested against placebo. And we see that treatment B is exactly the same as placebo in the trials that tested it. We have a relative risk of 1.0, so it was shown to be exactly equivalent to placebo. But we see that treatment A caused a 50% reduction, or in whatever the outcome is that you're testing for. And now we apply a little mathematical trick. You can imagine that if treatment B and placebo are exactly the same, and treatment A is 50% better than placebo, then treatment A has to be 50% better than treatment B. And basically, network analysis is just a very powerful, computationally intensive way of doing this across many, many of these nodes and edges. And it allows us to make comparisons of drugs that have never been tested one against the other in real life, but they have been tested against the same thing at some point. So we went ahead and actually, before I do that, there's also some additional information you can put into these graphs. The size of the nodes can represent how many times that particular therapy has been tested, and the size of the edges represents how many trials have been done, or how many babies have been randomized. So we went ahead and did this in neonatology for postnatal corticosteroids, and this is an ongoing project. I'm going to just give you a taste of the results that we have so far in this collaboration with Roger and Susanna Hay. So here we see the evidence landscape for postnatal corticosteroids given after 7 days of age, so late postnatal corticosteroids, for the particular outcome in this case of death or BPD at 36 weeks gestation. And what we see is that there are trials that have compared hydrocortisone to placebo. There are trials that compare high dose to placebo, low dose to placebo, and there are even trials that have compared high dose dexamethasone to low dose dexamethasone. But we haven't got anything that compares hydrocortisone directly to dex. And obviously, when you're making the decision on rounds about which steroid to use, it would be reasonable to try to get some estimate, if there were one, about which one is better. So for that particular situation of late steroids, death BPD at 36 weeks, these are the numbers that come out, and they're basically similar to what we saw with the traditional meta-analysis, but I will highlight for you that the confidence bounds around many of these are quite broad. And when we run this through the network meta-analysis process, we see that there is, in fact, we are able to compare hydrocortisone to high-dose dex, and it basically shows that dexamethasone is superior to hydrocortisone in this situation, and that low-dose dexamethasone is also superior significantly to hydrocortisone for this particular situation. Now, these graphs can get quite complicated, and trying to decide which therapy is better, you know, if you're not going to use placebo or hydrocortisone, should you use high-dose dex or low-dose dex, and what if there are potential for consequences of one or the other, which should you use? And so the network analysis goes on to try to rank the therapies that we have using a graph that looks like this. And basically, these graphs show the cumulative ranking on, if we test the process 10,000 times in a computer simulation. And you can see for high-dose dexamethasone, for example, at the bottom left, that out of those 10,000 runs, 95% of the time it was shown to be it ranked first in terms of its outcomes compared to all of the other results. Low-dose dexamethasone, 95% of the time was in the top two, and hydrocortisone and placebo, most of the time, 60% of the time were third, and another 30% of the time were lowest. We then basically apply something called the sucra, or the area under these curves, and it gives us a percentage, essentially, of that gray area compared to all of the potential area that it can have, and that allows us to rank all of these. So we see that for that particular situation, high-dose dexamethasone ranks with about 95% probability higher than low-dose dexamethasone, which ranks higher than hydrocortisone, which ranks higher than placebo. Just to show you the result for one other outcome, it's cerebral palsy in the same situation, late systemic steroids given after 7 days. And here for cerebral palsy, obviously placebo is very low risk, and it's ideal to not give anything if you don't need to. Low-dose dexamethasone ties with that, followed by high-dose dexamethasone. And interestingly, the randomized trial literature suggests that late hydrocortisone is actually worse. Now, there is a significant caveat here that the hydrocortisone result is based on only 50 patients in one trial. And so even here, where we have a cool way of analyzing the data and spitting out results, we have to back it up. And in the end, the uncertainty requires us to actually read the actual literature and understand what goes into this. But certainly we don't have the evidence, based on randomized trials, that hydrocortisone is safe. In fact, the signal is in the opposite direction, potentially. So that adds basically, this network meta-analysis so far has basically added 0.5, this idea that high-dose and low-dose dexamethasone seem to outperform hydrocortisone for late use for prevention and treatment of BPD. So how do we know what we know? Well, here are 4 ways that we can know what we, or understand what we know, and how we can wring data out of the randomized trials. Obviously, we have to decide based on what comes out of these meta-analysis what our next steps are in terms of performing randomized trials. And I think to be honest when we're at the bedside with ourselves about what the literature suggests we should be doing as a way of reducing, or at least assessing, the uncertainty that we have in providing care for our babies. So I'll leave it there. Thank you, and I'm happy to take questions about it.
Thank you so much to our presenters. We're really excited by this. Some great chat coming in. I know we're going to have some great additional discussion and Q&A. So I'm just going to remind you to make sure that you continue to chat in. My apologies for not having the update from Zoom, that when you are chatting in, please make sure you're selecting everyone. That's more intuitive than all panelists and attendees. So we're happy to have that. We're going to ask our presenters to turn their cameras back on, and I'm going to hand over and thank all of our presenters, Roger, Eric, and John, And we're going to invite Eric to start first and share a couple of updates from his previous presentation. And I'm going to hand over to my colleague and friend Roger to moderate this part and the discussion.
Thanks, Denise. We'll start with Eric. I've asked, when I invited everyone back to this session, I got from John Zapanzik, oh, we're going to get the band back together. But just for any new versions or little twists on the song, I've invited Eric and John just to share 1 or 2 slides to supplement anything that they thought was important in the intervening year. So let's start with Eric. And what do you have to add to the whole issue of definitions?
Thanks so much, Roger. It's great to be here, and I've enjoyed reading everyone's comments in the chat box. So one of the important things about, I think, any definition that we're going to apply in our field and in medicine in general is can it be validated in external cohorts? Is it widely applicable? Does it perform the same way when we use it in different populations? And so we are waiting, to the best of my knowledge, I have not seen any publications that look at the definition and childhood outcomes, but there are a couple that have come out and looked at in-hospital outcomes. The first is shown here, some work that we did using the Vaughan registry, and it shows data that are remarkably similar to what we observed in the NRN, the cohort that we used to derive the definition that I spoke about in the first presentation. And we see rising rates of in-hospital morbidity, be they respiratory, such as home oxygen therapy, tracheostomy, as well as other major predictors of neurodevelopmental disability, such as ROP. Late in hospital death rises and is shockingly similar in rate in this cohort as it is in the population that I described in the original presentation. And we see increasing duration of hospitalization lengthening as a child advances from different stages of BPD. Can you go to the next slide, please? And so this here is data that I had no involvement in, so I can't claim to have any bias towards it. It's information that comes from the Children's Hospital Neonatal Consortium, and it's a group of hospitals that are all referral based. So it's going to be a slightly different population. These are not generally inborn hospitals, but those who are receiving patients from other inborn units. But even in this cohort, that's relatively large, over 4,000 infants born recently, we see that same pattern with rising rates of morbidity in hospital at the time of discharge as BPD severity increases. More use of home bronchodilators, more use of at-home inhaled steroids, higher rates of gastrostomy, fundoplications not shown here, but it also increases tracheostomy, more in-hospital death. The exact same rate, 13%, is seen here as was seen in the Vaughan data, and then again, longer lengths of hospitalization. So the more that we see this definition applied in the literature, we're finding that it performs reasonably well, if not better. This last publication shown on this slide compared its performance to the 2018 NIH workshop definition, and it performed, the one that we developed, performed better in terms of strength of the association between BPD severity and these various measures of respiratory disease. So I think we're learning that it performs quite well. It has limitations. I'll be the first to admit to that. But externally in other populations, I think we can feel fairly valid, at least for in-hospital, that throughout the NICU world, it's been performing reasonably well.
Thanks so much, Eric. The chat is exploding, but I'm going to let John sneak in with a quick update to the network issues, and then we've got lots of questions, many involving the issue of both definition and some about choices of treatment.
Thanks very much, Roger. I actually have questions for Eric too, so I think we're going to have to extend this whole thing. I have just put up a link to a Cochrane webinar that Roger organized from June, I think. And basically that webinar includes Roger, Susanna Hay, who I referenced in my talk in this 2019 that you just heard replayed, and others who have taken that network meta-analysis forward and got more detailed responses or results that I think will help to answer some of the questions even that are coming up in the chat. High-dose dexamethasone decreased the risk for failure to extubate. It increased the risk for GI perforation if given early. Late dexamethasone decreased the risk for failure to extubate and increased the risk for hypertension. The results for the primary analysis, primary outcomes rather, from the network and meta-analysis were essentially the same as what I had shown you in the last talk. And importantly, if you can advance to the next one, please. Importantly, the ability to combine all of this information into a network meta-analysis, as it turns out, when that network meta-analysis was made more complex and included, for example, levels of dosages, it didn't actually end up adding very much to the existing systematic review evidence. It showed that, as I said, high-dose dexamethasone is likely the most effective treatment, but it also had the most adverse consequences. And it basically shows us that in the end, regardless of how we synthesize the results of randomized controlled trials, much of what we are going to have to do is to decide on better treatment questions for those trials, to ensure that they are very well done trials and large enough that individually they take care of statistical uncertainty well, and that the aggregation of those trials is something that will have to happen post hoc and depends on the quality of the original research done. So I think for this particular outcome and this particular series of interventions, what we see is that it is not the aggregation, it's not the research synthesis that is most important, but how we do the original studies. That's a slightly dissatisfying result. We had hoped that we would get much more nuanced information about hydrocortisone versus dexamethasone and so on. I will also say that one of the significant limitations of this literature is that if there are never any comparisons done between competing therapies like hydrocortisone and dexamethasone in real life, it makes it very difficult to draw the graphs that we talked about in the prior analysis. So I'll leave it there. I urge you to log in to the Cochrane webinar as well if you have another hour or so at some point, because there's a lot of great information in there. Thanks.
Thanks, John. This issue, our research does seem to peter out once we decide what the champion is or what we think we've shown to be effective, and becomes very unnuanced in terms of these choices about who to treat and when to treat. I'm going to ask you first, John, because then it's exploded with definition questions, but let me ask you a treatment question first. There doesn't seem to be, from these analyses, any great support for hydrocortisone, and yet we saw from the IPD that it seemed to support the use of hydrocortisone, and we know in Europe this is a very, very popular therapy now, particularly based on the bowed work of early hydrocortisone. Then juxtapose that to the more recent, in the past year or two, Canadian recommendations, which say there's no role for hydrocortisone. Any comments from the analyses? Any wisdom on those points?
I think, as I alluded to in the past, the presentation from 2019, it's, how we look at the literature is a little bit of a Rorschach test. There is substantial uncertainty around the trade-offs, in particular, between risks and benefits for both hydrocortisone and for dexamethasone. And I think that depending on how one accepts that trade-off, one might choose one direction or the other. There's also obviously a lore around practice and a comfort with how we which medications we order for a particular situation. So I think that what we're seeing when we see variability, one of the first things variation rather in practice style, one of the first things that I look for is whether the underlying evidence is uncertain. And so I think the situation that you just described essentially underlines the fact that there is not a good answer that falls out of these comparisons. And as I said, we don't have a direct comparison that helps us to determine practice.
Yeah, thanks, John. So fair enough. So Eric, there are lots of definition questions. First, probably a simple one. What should we do with the infant with a chronic respiratory insufficiency that was born after 36 weeks? How do we categorize that infant? The lung disease of the child with a diaphragmatic hernia with chronic ventilation?
The shortest answer is I don't know. A more nuanced answer would be one thing that you could do is the 2001 NIH definition provides criteria that can grade BPD severity. Those, to the best of my knowledge, have never been validated. The Ehrenkrantz paper that came out in 2005 only looked at very preterm infants. Our data was developed, or our definition was developed only in very preterm infants. So if you're looking for a definition that's been published, that one is there for you to use. An alternative would be if there are groups of people who are very interested in wondering how we should define it in CDH or in lung lesions or in children who have persistence of RDS but are born at 34, 36 weeks, then I think that's an area where a definition should be developed based on imaging or clinical support characteristics. Certainly, I think if you're dealing with something that's not beginning with an RDS phenotype like a BPD thing and you have a CDH or something else, then applying our definitions from the preemies is probably not appropriate and should be avoided. But I think if you want to have something to use, you could use the 2001 the 2001 NIH definition because nothing else exists.
Fair enough. So much of your work with definitions relates to BPD as an outcome, but so much of our work in the NICU is about treating whatever this evolving process is. How do you think that your definitions or your work has helped us in predicting the infant with BPD and what we're trying to predict and what we know about those evolving risks? And does your definition change that assessment?
Yeah, good question. So with respect to predicting it, I don't know that it has a huge impact. I think that we're finding that predicting the highest severity of BPD is a bit more challenging when you separate out children who are on non-invasive support from those who are on invasive support. It's easier to predict a child is going to be on some kind of positive airway pressure at 36 weeks than it is to predict this child is going to be on invasive ventilation when you're using data collected in the first few days or the first few weeks of life. So I think that adds an additional challenge. It's not a huge change in predictive accuracy, but it is one that is significant. I think it becomes problematic to know when therapies should be initiated for the treatment of BPD. The timing of diagnosis, 36 weeks or whatever another person prefers, is by convention. It's pragmatic and it's something that can be used to think about prevention of BPD and the long-term rates of BPD. But knowing when to begin a therapy to treat the ongoing broncho, lung, and pulmonary dysplasia that is a result of being born extremely preterm is challenging. And ultimately, I think therapies are going to have to consider the mechanisms that are responsible for their benefit and employ them when they think they would be most useful, and then study them in trials and look for improvements in outcomes. Ideally, childhood respiratory function, but short of that, things that are in hospitals, such as need for home oxygen therapy, infant PFTs if they're available, duration of respiratory support beyond 36 weeks are all reasonable things to begin with.
John?
Eric, I wanted to ask you a question that is kind of at the other end of the spectrum. This is one of the few outcomes we have in neonatology where we have focused all of our effort, or almost all of our effort, on essentially a surrogate outcome. Randomized trials of neurodevelopmental outcome would probably, in many cases, are not fundable if it were based on MRI results at 40 weeks. We go out to 18 to 24 months or even longer, and we say that is the appropriate outcome for an intervention. And I'm wondering what your thoughts are about extending this definition and thinking about what the standard definition should be in the very long term and at 24 months and considering this, as a good but surrogate definition of lung function for our children.
Yeah, that's a good question. I might challenge you a bit on the notion that this is the only example where we have a surrogate measure. I think even 18-month neurologic outcomes are surrogate measures. I mean, I think our goal is not to make a smarter 18-month-old. Our goal is to make a smarter child and smarter adult and a longer living, healthier person, someone who carries on a long, productive life and is able to contribute to society. And because of the expense of these studies, we've limited to 18 months, but a lot of the Barbara Schmidt work has carried out evaluations through 5 years and 11 years, and we're seeing different effects of therapies when we follow those children longer. But certainly BPD, when it's diagnosed in hospital, is a surrogate in the way that we've developed the definition because we've based it entirely on what predicts early childhood morbidity. I think to a certain extent, our other definitions also fulfill that criteria. IVH is an example. It's meaningful to us because the worse the IVH, the higher likelihood you are to have adverse neurologic health when you're older. But as we develop therapies that will hopefully both prevent BPD and treat existing lung disease, it will be incumbent upon us to develop outcomes that are meaningful, that can be measured at 2 years and at 3 years and at 5 years. There's important work that's going on now by Sarah DeMoro looking at functional outcomes. So not just pulmonary function testing, but is a child able to do a 5-minute walk test? Are they able to perform athletic activities similar to their peers without having shortness of breath? So I think things that measure a child's function and ability and overall quality of life will be very important as we evaluate if therapies are effective in the NICU for reducing respiratory morbidity.
So we're going to be running out of time soon, but I'd like to throw Eric one more question. I know you said ultimately you're still comfortable with a treatment-based definition, but there's so much in your talk and so much in the chat about the aspect of the wastebasket nature of the BPD definition, the basing it on treatment as opposed to some of the phenotypes that you discussed and the underlying problems. What do you think the future of the phenotypic definitions for these chronic respiratory insufficiencies are?
Yeah, my guess, and I'm not much of a gambler, so I'll grant that I could be wrong here, but I think it's going to be this big sort of nebulous gray area where people are doing a lot of different things for many, many years. And then hopefully at the end of that tunnel, there will be a series of diagnostic imaging procedures that have high inter-rater reliability. My anticipation, based on what I know about the technology now, is that those may rely heavily on computer-based technology that can provide good inter-rater reliability. We look at the information we have about CAT scan and echo, and all of those carry deficits where one reader sees one thing and another reader sees another, and it's going to be very challenging to have a uniform diagnosis when there's so much subjectivity to it. So if we can apply technological means to standardize the measurement of lung disease on imaging and heart disease and airway disease and lung growth over time that can be uniformly applied at set time points, I think we're going to get a lot closer to having a physiology and imaging-based definition.
Great. Well, thanks, Eric. So I'm going to take the opportunity to thank Denise for inviting us back and throw it back to her to conclude.
Thank you so much, Roger. And thank you, Eric and John, for sharing your time again with us, your wisdom and your inspiration. So we want to encourage all of you to join us for our virtual 2021 Annual Quality Congress. We have programming that will span most of a month. So we have our quality improvement collaboratives who will be meeting toward the end of September and the beginning of October, and then a whole wonderful series of webinars. And Andy will go to the next slide. We'll focus on our plenary day. So this will run from 11 a.m. Eastern through to 5:15 Eastern. and we will touch on deep learning, health equity, mother's own milk, transition from gavage to oral feeds, transfusion practice, strategies for a comprehensive pain program, and family-centered care as a key means of neuroprotection and promotion of healthy neurodevelopment. So we encourage you to join us that day. I know my colleague Drew put a link in the chat for you to register, and I know he'll follow up with additional messaging to you. Next slide. We very much want to welcome you to join us if you are at all interested and you know at your center you have opportunities to improve your rates of BPD or any of the other clinical outcomes of interest to you. We have a wonderful collaborative underway to improve critical transitions. We have evidence-based practices that will help you to do that. So you're welcome to contact us, and we're happy to meet with you and follow up to explore how we could better meet your needs. Next slide. We also have a Responding to Neonatal Abstinence Syndrome course available. We'll be launching 2 more courses in the coming months, and those are open to all staff in Quality Circle centers. That also includes our internet-based Quality Improvement Collaborative on improving critical transitions, and everyone at your center who participates can earn CME and CNE. Next slide. I want to thank our presenters. I want to thank all of you for being with us today. We look forward to seeing you next month at our virtual annual Quality Congress. Please take good care, and thank you for everything you do to care for the infants and families. Bye for now.